school at Case Western and residency at OHSU. He works at the Richmond Family Health Center and also does buprenorphine treatment in pregnancy. He enjoys sailing, skiing, and motorcycling.
Same time.
All of it. And he's here to talk to us about patient engagement. He has indicated that he has no relationships to disclose relating to the subject matter of this presentation. Welcome.
Thank you very much. Well, I will confess that Evan stole a little bit of some of the thunder on this, so there are going to be things I will probably dive into a little bit deeper as we go through some of the aspects that he spoke about. And I'll be trying to really emphasize some of the structural things you can start, if you haven't already, continue to bring to your practice to enhance patient engagement at a number of different levels, in addition to the kind of care planning stuff that Evan was talking about that's so important for coordination and integration. And I think I have a couple answers to a few of the questions that were posed in the first session for those of you who are here for that one as well, including some around the payment and the kind of investment your practice might need to make to see some of this happen, and where some of the payoff will be with putting the patient-centered back fully into the patient-centered medical home concept. I'm going to start with my thank yous. I didn't write them out on a slide, which is I regret, because it's nice to see them up there. But I first want to thank the team at Family Medicine at Richmond. It's been a roughly 6-year process for us after seeing little bits of it at IHI and other places, particularly visiting South Central Foundation in Alaska. It's taken the leadership of our board, one of our board members, Mary Lundy, is here. It's taken the leadership of our executive directors, Ann O'Connell and Ern Tiber, to support this kind of work. The Department of Family Medicine has let Richmond's lead on some of this stuff and become a fully federally qualified health center. We'll be celebrating our year anniversary of that in June, which has also created additional space and learning collaborative opportunities. Many of these have come to us first through Care Oregon's primary care renewal project. Again, about 5 years of that formal with some very modest, just a couple of % on our budget funding, but a lot of that has laid the groundwork and given them breathing space to do some of this intentional work. And then later the Safety Net Medical Home Initiative that Oregon and many members of this room, not just from federally qualified health centers, have been involved in. Much of that has gone through the Oregon Primary Care Association, for those of you who are in the safety net world. So thanks to all those folks for giving the space and time to do this. And why did I get picked for this? I think last year I did Access, real math stuff. I used to really like math and sort of business planning, and how can you measurably get to a place where you can enhance continuity and relationships and get our patients in when so often it seemed like we weren't meeting the needs of our communities. This year, and that's something I felt I've been working on for a number of years, and of course have a long way to go before it'll be perfect, but I think it's something I feel like I really know about. This is the talk you pick because you really want to learn more about it. There's other people in my clinic, particularly Christina Milano, who some of you know, who've really picked up this mantle and run with most of this work. But I know we need to go farther, so this has been my chance to more deeply dive into what some of the tools are, to make sure that we're rolling them out at our clinic as well, and move forward on patient engagement.
Nick, do you want me to just advance the slides?
Sure.
What do you want to do?
Thank you. So this is the agenda I have, and this is my chance to do some agenda setting with you. Certainly I'm going to just quickly review where the standard 6 fits in the criteria and what they currently are. I will call that a fairly low bar because I think that's been harder to describe than some of the measures like access and continuity, and even evidence-based quality work, where there's a lot of stuff out there. Certainly I want to loop back to what's oldest about this, what's core to our identity as Oregon family physicians, probably why you chose your residency and specialty or your training or whatever path brought you to generalism, and then really try and interface that with what is new in our practices and technology. I'm going to spend some time in group visits, who here is running formal group visits, diagnosis-based, not diagnosis-based, any kind of shared medical appointment, group visits, stuff like that? A couple of us, 3 of us. Okay, great. So we're going to spend some time with that, I think, because I do think it's a technology. It has its pluses and minuses. It clearly is successful sometimes and less successful others, and I want to talk about what's worked for us or what might work for you. We are going to spend some time on the care management plans that, again, Evan touched on. I am going to spend some time around where I see, there was a question in the back about, how are we paying for this exactly? And the evidence shows, like you probably did learn way back a long time ago about not interrupting and letting the patient finish talking will save you time. The evidence shows about a 90-second reduction in a complex patient visit time using some of the tools that I'm going to be describing and going into a little deep here. This is, quite stolen from Larry March, who at least 1 or 2 of you I know have seen in the patient center observation forum. I'm going to be showing some of that stuff and just a little bit of touching base on the motivational interviewing and Oregon SBIRT. Who here has currently got an SBIRT up and running at their clinic? Wow, I'm feeling really good because both of those last 2 questions I was expecting hands up all over the room. Because you're all pretty much going to be, right? My understanding is that it's been pretty much adopted as a core CCO measure. So whatever CCO you're part of is going to probably kind of mandate or make you, or you're going to have to, if you really, really don't want to do it, you're going to have to do a bunch of other stuff to make up for not getting those brownie points. So I'm going to spend a little bit of time just with sets that come right off the SBIRT Oregon site. I want to train you to get into that. Because it's been tremendously helpful as well as a model of how you talk about stuff. Certainly not limited to alcohol and drug alone. So other topics when you picked this room to walk into before lunch on Friday, is this a good list? Is there something big in patient engagement that you want me to add to this list? Okay, good.
Just literacy.
Yes, I will be touching on health literacy, a couple of the tools around that, and the imperative around that. Thank you very much. Good. And if I don't, make sure I get to it. So many of you have maybe seen this slide before. I use it for everything. 75% of the U.S. healthcare dollar is on chronic illness and chronic illness care at this point. We long since left the model we kind of invented when we got x-rays at the turn of the last century and penicillin in the middle of it, of everything being cured with the one correct diagnosis and plan. This is stolen from Doug Eady up at South Central. And it's just on the y-axis we have the locus of control, and here we have the acuity. And so much of our drama and our training and our TV shows and plenty of money happens in the ICU where we, the medical industrial complex, has all control, right? We're dialing people up, we're dialing them down, they're intubated and paralyzed, we don't have anything. They're not making any care plans. And we have absolutely all of the control. However, chronic disease and most of our issues live much farther into the other end of this curve. The processes have been going on for decades by the time they come to our clinical attention, and indeed, much of the care planning that we're talking about here wholly resides with my patients. I'm not going to go home and check whether they're taking their medicines. I'm certainly not going to be doing their diet and exercise for them. I'm not going to be implementing the care plan when they wheeze in the middle of the night. It really relies on them. This has lots of implications for access, for a behavioral system that works when people need it, not when they wait long enough to get that scheduled 6-month follow-up. And it certainly has a lot to do with active care management and patient engagement in not only their own health, but the way we provide their health care to them. Next, thanks. So Schroeder's article in New England Journal of Medicine 07 gets cited all the time. Again, we kind of all knew this before 2007, but it's been put out there nicely in this Shattuck lecture there, that behavioral patterns contribute about 40% to people's health status. Genetics, lots of whiz bang, but 30% that most of us aren't going to be able to do tons about. Social circumstances and a pitch for the medical home. If you get people insured and you give them a good, robust primary medical home, you pretty much erase health disparities based on socioeconomic status and racial barriers. Health literacy is probably a big glue to that. We no longer think vitamin D is the glue to that anymore, right? For a little while, vitamin D was the whole answer to that 15%. But we know this. We kind of already, this has been shown well, particularly in Massachusetts, that a robust medical home plus coverage erases much of the health disparity that we spent the last decade kind of talking about and not getting much better at. Environmental exposure, important in the social circumstances also as well. And then actually the kind of care we deliver, around 10%. So patient engagement is the way you're going to get at this big chunk of the puzzle. Thanks. And what are those particular behaviors? The list is not that long, which is kind of nice for implementing actual structured written plans and labeling the patient chart. We'll talk more about where that specifically can live. But smoking's huge, obesity and activity. They don't list the diagnosis of hypertension. You will also hear people say that hypertension is next to smoking in terms of preventable years of life lost, but obesity and activity is closely related to that. We spend a fair amount of time, I spend much of my practice around opiate dependence and buprenorphine, but it's actually not that huge number. Guns are certainly in the news right now. Motor vehicles dropping. I think in Oregon these bars would really be pretty close, right? When we say in Oregon number of lives lost and years of life lost are now as high for opiate overdose as they are for motor vehicles. Alcohol and its physical effects, and sexual behavior. Again, fun to talk about, but in terms of health burden, yeah, excellent. All right, so when this is somewhat taken from John Saltz, there's and Bill Miller in the first round of testing of comprehensive medical health. There's these core attributes. I won't go on to that, except to list, to go into these in detail, except to say that I'm talking about this contextual part. The part where we talk about relationship-based medicine. We went into family medicine because we like to know our patients and take care of them in a full biopsychosocial model in the context of their community. And that's where every one of your practices in your microenvironments is different. I was reading the list of folks who are here and the communities you live in, and I still play around a little bit out at Blue Mountain Hospital, and really my weekend in John Day is really different than when I'm on call for a weekend in Portland. And it's this contextual part that is holistic and very patient-centered that I'm spending the time with today. So what gets added on to the magic of primary care? Some of the chronic care model fits pretty well, kind of, with patient engagement, particularly when we have these sort of specific system and physician often driven action plans. But the idea of the chronic care model and what we've gotten from Seattle from that, certainly the patient is consumer, which I think, I was just on the drive out today hearing more about the hundreds of people who will be in call centers to help get our health exchange running and our insurance and getting these folks covered through mechanisms where they're at least making some choices about how to sign up and how to work with the CCOs. And then the advances of information communication technology, we'll be talking a little bit more of those additions sort of to what I said of the previous magic of primary care from Bill Miller. And then we certainly have this whole set of social influences, and I'm going to add social media in terms of the fact that, I don't know about you guys, but I am being actively marketed right now a variety of ways to communicate with my patients in some fairly automated ways, still in conjunction with my medical home, but we haven't invested in that sort of thing yet, but it's going to be there. Okay? So, again, I won't spend much time. These should be pretty familiar to most of you, these domains. I'm talking about the last domain, but we still love the patient-centered language that all of these were described in. And there's a threat in here. What's the threat in this sentence? Yeah, this
We can't be everything to everybody.
I think the thread is about this responsibility. In my darker moments, when I thought maybe, healthcare as we know it through the Affordable Care Act was going to be repealed or something else. And these sort of drumbeat of the personal responsibility, and you link that with some of the health behaviors and the way judgmental attributes to sexual behavior or guns or the way people drive or certainly the way they drink, certainly the way they smoke work. I think one of the things the medical law may be designed to do is that when we say no, right? When we say no, some things aren't going to be funded in the way they used to be, you're still going to have a medical home to live with, and you're still going to have some patient responsibility around that. This is, again, one of those bad memories from the 90s, but it got quite in vogue to fire all the smokers from your practice. That made the front page of the papers. I'm seeing nods around the room, right? Now, it was generally crass cherry picking, but I still see it with opiate dependence all the time. That you wash your hands of it, and there's a sort of mixed incentive to do so. And I also think part of what we're talking about patient engagement here is if we can't control, because the jury's still out on how much does a really good integrated system like Kaiser really cut costs. It does lots of things well, but it hasn't really beaten the inflation piece yet. We're betting high in the state, we're betting high stakes on beating the inflation piece. But when some choices need to get made down the road, some of them are going to have to do with patient responsibility. I'm quite sure of that.
Another barrier here is coordination and integration. In my practice situation, the number of cardiologists is tripled. And so I have patients who are seeing cardiologists much too frequently for far too many unnecessary diagnostic tests, and so there's going to have to be some kind of oversight, or else we're going to have to be given it, or our CCO is going to have to do it.
Right, yeah, and certainly without the patient engagement part, I can do a lot to protect my patients from non-evidence-based over-intervention, but I need my patient engagement to do that, right? I will tell one quick story from the field. I think I've got a second for this. I am happy to say that at least in the Portland CCO area, they're on this like I had never expected. I'd kind of been telling people a year or two ago that once you start saying to a cardiology group, here's $3 million to care for 20,000 patients, go at it. And by the way, we're going to be looking at whether your risk stratification is evidence-based or not. I kind of thought behavior could change really fast. I got a little skeptical when I saw things like the dental carve-out and all this other stuff, like, hey, people are starting to position to protect their interests. But at least I'm sitting at tables right now in Portland with cardiologists who completely get it. And in fact, they're probably trying to push stuff towards me a little bit, right? And we'll negotiate that, but I'll take it. I'll take it. Because without getting pushed towards me a little bit, if I'm resourced to do it, I think in 4 weeks we're going to have a weekly video teleconference at my clinic going over every patient with CHF and AFib and saying, what's their CHADS, what's their anticoagulation pattern, when's their next risk stratification, just boom, 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 with guidelines that they give us and clear sets of who they're going to see once, and who they're going to see never. And I thought that was going to take a year. So that's just one piece. But and I certainly put this up here because this is all completely interdigitated and glued together. It's very hard to separate each of these domains, but it's not hard to pick what you're going to do. So let's start talking about that. So quickly to go through the current attributes, like I said, I could call this a fairly low bar. The only must-have is some ability for translating work. So this big set of promises here has been boiled down to, do you have some translation services available? Do you do something in a self-attestation way to say that you work? And the list is fairly long of things that you can choose that provide education. I mean, really, you could probably have, correct me if I'm wrong, but if you have a file cabinet with a handout for asthma and a handout for low back pain and a handout for hypertension, you're probably there, and we're talking about something very different, as you'll see in the next few minutes. And then this part of experience of care. I'm not getting deep into patient satisfaction surveys and literature and benchmarks. That's not what this talk is about, because while that's very important, and I'm about to launch into patient engagement in other ways with our practices, I'm going to leave some of the basic, are you surveying your patients and are you getting those results? I'm going to leave that because it's well, frankly, it's relatively plug and play, and you can do that, and what counts is whether you act on it. And taking those raw scores and turning into something you do in your practice is a very big piece. So I'd rather talk about that than simply patient satisfaction. The other thing is that it's just going to be very hard to work on patient satisfaction. It's often a very hard number to budge, and there's a lot that goes into it. I know it's probably an excuse, but when 75% of my patients say they're anhedonic and melancholic on a PH2Q screen, and 47% of them are scoring more than 8 on the PHQ-9, I'm not sure how happy I'm ever going to make the whole group. I should make them happier than I'm making them, but really, yeah.
I guess that's one of the things I like about the reframing of this, is we're actually asking about the patient experience,
Yes.
not patient satisfaction. So saying, in a good visit, you're seen within 15 minutes of arriving, you understand the instructions you were given. And I actually do, I mean, one of the reasons I'm here is I feel like some of that patient activation engagement is what's gonna move our experience of care scores.
Amen.
If they're not understanding me doing what I'm doing, I need to do something different.
But I'm also hanging my hat, and as you see, as I get into this patient-centered observation form thing, it's like our main initiative around patient experience and care and satisfaction. Some of the others that, are you measuring whether they can get in, or is there continuity rates? Those are a different set of systems, but yeah, next. So I'm not, we've already kind of gone over that, keep going here. Unless somebody really want to talk about those points. Okay, thanks. All right, so again, I really want to emphasize, which has been true for all of us for a long time, that this is about the relationships. They come first. Your engagement with your patient is based on this respectful, peer-oriented at times relationship, sharing what you know about them, what you have over time. Those of us who still do maternity care, seeing, it sure is easier to take care of that ear infection if you delivered that kid, right? All this stuff. It sure is easier to know what's going on at home when you care for both members of the family, or you care with whatever members of the family that you care for. So this set of context, family, community, faith, education, and knowing what your community resources are. Certainly when I was in Cottage Grove for those 8 years, it was pretty easy. I knew what those community resources were. It was pretty easy to know whether people were accessing. The list wasn't hard. It's a little bit more diffuse in Portland, but then it's up to me to define it better. Certainly the EMR. Who here is not functioning with an EMR right now? So, wasn't that many years ago that we would have been switched around in the room, probably about a half a decade ago. But certainly we're going to spend some time talking about where a care plan can live in the EMR. Certainly this idea that also gets back to, the devices we're all living by, of information continuity and the ability to kind of tap back to a care plan, tap back to a resource list, tap back to a behavior change management tool easily and kind of at any time. The development of databases, some of which work out of our EMR, some of which don't, and other kinds of this was a funny spell check, and I thought it was sort of SoCal media, but social media and whether this will become something we integrate into our tools. Next. All right. So what are some core things? Now these are things that are really easy to say, and I would like to say I describe, but I know, if you were God and you were watching in the exam room every day, or on that phone call every day, you wouldn't always see complete respect around my patient interactions. Do I really know what those family values are in that? Am I able to respond to the expressed needs? How do we, Keith, you mentioned, a lot of our medical industrial complex has gotten pretty good at making people passive dependent consumers who expect us to meet all their needs, like meet all my needs. How many of us this week probably had a patient with some painful condition kind of put it on us to make that go away, or take the primary responsibility for that around it. How do we really, and sometimes I've seen in my partners, some of those easy monthly follow-ups, kind of checking the same thing. I had a colleague in Cottage Grove who went to work at a very small practice in Veneta, and well described the kind of, you really need to see someone every month to talk about their cholesterol, but the system can get set up like that, and if it's kind of working for everybody, people will do that. So how do we really expand people's roles in their health-related behaviors and decision-making? Certainly we need to do it by being in a culturally appropriate setting and very much at a literacy level that works for the patient. And we need to integrate it in some way or another, like we sometimes do with like we've gotten much better with our prevention work, integrating into VESIT so that it's easy and accessible there. And then obtaining feedback, not just the survey stuff, but real feedback from patients and family about their experience and using that information to change our programmatic work. So you'll see a lot of little acronyms around that, but what is it that we do when we're supporting self-management? We're trying to aid and inspire. We're being directive, but inspirational, to become informed about their conditions and take an active role. And it's, we all love, for those of us who had some time with Tom Bodenheimer and his habits of successful healthcare organizations and all that stuff. Yes, it's a portfolio of techniques and tools, but back to that sort of core value we have as family physicians, it's really talking about transitioning the patient-caregiver, patient-provider relationship into a really collaborative partnership. And that's the sort of evangelical spirit part of it that I want to make sure we keep talking about. Next. All right. So let's just talk about one technology for a minute. There's a lot in family practice management about group visits. Half of the articles are essentially postmortems, right? What were the barriers? How did they not continue to succeed? Because there are real challenges, right? Who knows what I mean when I say shared medical appointment? Okay, so let me describe that better. Shared medical appointment is you do a bunch of stuff together, but you see every patient too, right? And you really fulfill the elements for a 2 and 3 or a 2 and 4 or whatever it is in the context of having brought people together at a shared time. It's probably the most sustainable and successful model. For those of you group visits, is that your core model for this? Yeah, because it's getting you the real. I see about an extra patient an hour when I schedule those, and I'm scheduling a tough crew, particularly the buprenorphine patients with really high no-show rates and that stuff, but my average productivity is better than my average productivity another hour. Frankly, it's easier, and mostly because that's the shared efficiency of giving a speech once instead of 4 or 5 times. Debriefing once instead of 4 or 5 times. And that's not even about, that's still a very doctor-centered measure, but it's getting that work done, and it's also doing a lot to sort of blow up some of the access problems that we can have when we are using time-based scheduling. Turnaround time remains a challenge. I know that's something we're getting back on our surveys around the group visits, that when they were there in the clinic for an hour to see me because I was running 20 minutes late and then we do some stuff and then spend 20 minutes in the lab, that was one thing. But when it's this big group and they're only seeing me alone for half of that time that they were before, and this added time doesn't seem like it's all about them, turnaround time can be a challenge because it can actually go up. How you cohort the right groups, we're going to talk a little bit more about that, but some folks do want to be along. How do you get the right cohort together? How do you use your MA time efficiently? It tends to really press at the beginning of the group visit, maybe press at the end, and then have this sort of dead space in between. So we're just getting that dance together with the MA and the resources you have, and space. We certainly have real space challenges in terms of, do we have a room that's large enough, a conference room? When does the group size get small enough that you can fit it into a regular exam room? We use our procedure room now and did some redesign around our procedure room, got the supplies out of the room so that we could also use it as a group visit space, for example. But it's not what many of our offices were built for. And then this bit of cohort fatigue, which is really what I hear about the most, right? You set up a diabetes group, you've got a certain number of active engaged patients who sign up for this. They go through the curriculum. Right now, our diabetes at one of our colleague clinics at OHSU is a 6-month, 6-visit curriculum. And by the end of it, you're just done. So if you've done that for your whole group, do you stop having the group visit? Do you keep that going or not? Can people drop in or drop out? We're having one on physical activity and motion where we're not sure. We're going to have a drop-in group compared to the set curriculum group. And see whether that works. So I think that's also a very large part. Now, if the work's been done and that group has met and they've all received the basics, and they've developed care management plans, and they provided some peer level of support. And some, that can be a good thing. It just isn't clear how long and what your capacity is going to be for ongoing group visits. Next. Some tools that have been very helpful for us, and I've seen us develop and have gotten much better over the course of our group visit work, and diabetes, buprenorphine, some urgent care group visit work, now chronic pain, and probably adding a morbid obesity group, is having the right intake form isn't really the right word, just the right questionnaire that asks all the questions that you would have asked. Those, it's taken in my group visits about 3 iterations to get the language better and better. Patients have helped me with that a lot, right? The first forms were kind of my visit note template written down and needed sort of translating for people to really fill them out. Then we took one level of turning into real sentences and obvious questions, and then we took it another level by picking the right engaged patient really to help me co-write that.
Do you have those forms available somewhere that people could use?
They're specific for the diabetes, the buprenorphine group visit right now. I'm pretty sure, well, those are the 2 that I know, so yes, I would just, my email would be on there again, and would be happy to share those. Yeah. There's also the consent, which happens for the initial group visit, that basically says, this is convenient for peer support, for efficiency, and for access and scheduling. Realize there's some privacy issues and respect your peers. So we have that happens once, the first group visit that someone intends, and then that's filed forever for those. I mentioned space time and how to do this dance around the individual time with the provider. Very useful focus groups, very useful to have guests. Again, I'll use the buprenorphine example where our pharmacy had some really basic questions about why people were doing their refills like they were doing. All the way from the most concerns about diversion, all the way to other money problems, all this. Nothing like taking a new pharmacist and bringing him to boot group like once. I mean, a new social worker last week, bringing him to boot group like once. And they learn everything they need to know about you from one focus group. It's much easier for people to talk in that setting in some ways. I find that it really increases a new person in the group, increases the talkativeness of everybody there, because they can talk in more general ways, right? It's sort of de-identified. We'll talk about that a little bit more in some of the questioning techniques. Whether you have a curriculum like 6 set things for diabetics, and where the open discussion occurs. I will say at this point, I think the best open discussion usually occurs while I'm out of the room with one patient at a time, and they're there together. That's when I really kind of hear the buzz at this point, particularly on a well-established group. Next. We talked about that particular way. There is someone in Cottage Grove who does urgent care group visits like all the time, and we have done some of that in our Saturdays because the demand fluctuates and we kind of want to go home if there aren't a lot of patients on the schedule, that they're all at the same time. And we haven't gone through this formally, but the idea that you could really say, this is an urgent visit, what's your one problem, what's the one test or treatment you think you need, what can I do for you in the next 48 hours, when do you need to be followed up for this? That would be the structure, and it really wouldn't matter whether it was a sprained wrist or a bad cough. And that's still ongoing in Cottage Grove. That's been sustainable. And then mini groups comes out of, I'm sorry, I might remember the doctor's name, but the family practice program in Olympia, St. Peter's, I think it's called up there. Just says the one way to do the diabetics better than trying to sort of get these big groups of a dozen together with longer intervals and piling on all the other disciplines is to have a PCP pick 3 or 4 people for a 1-hour visit. So you're not trying to ramp up this whole efficiency, but they're matched. You're picking the relatively new diagnoses, or the really, really heavy set folks, or the folks who are really, really non-compliant around medication. You're just doing some social matching. You're arranging the party. And that's what mini groups were, and there's some evidence around those. Okay, next. All right, where should a patient-centered, patient-developed collaborative plan live? We're still often in the world of it being notes on a problem list. Really easy to see through your EHR and your paper chart on that front problem list page. Not very searchable. not necessarily accessible to the patient through their portal, would need to be printed or translated. We now have in OCHIN, anybody here on OCHIN? Good number of you. You've seen the patient goals thing has now shown up.
Of course, we got no training on how to use that.
Right, neither did we. I'm using it.
Nobody.
It's not, we haven't developed this clinic-wide workflow. The list is lousy. I don't even think quit smoking's on there. Right? But there is some pretty cool stuff on there, and it is in really plain patient-centered language, and I can turn the screen to it. So I think about a third of my patients, something's been clicked in there already. So I'm not sure that's where it's gonna end up living, but it's gonna be a really easy one to count. And I'm finding it really easy as I go through the visit navigator. So, dedicated places in your EMR where care plans or at least some patient goals and action plans can be done. Certainly the coin of the realm is, do you have written care plans? So at some point or another, nothing, something in Evan's talk got me reminded, what's my particular standard, what's my usual recommendation? I don't care what the exact standard is, just have one. It's like we sort of say about the pain management and the opiate thing. We could argue whether it was 60 or 120 or 180 milligrams of morphine equivalent a day. That's not the point. Just have one. Start and get something written down. So hopefully you can find a place where those can live. But really, what I want to keep diving deeper towards is this patient-oriented, evidence-based stuff that matters, that really works on the outcomes. So how do we get, at the macro level, more robust patient input into our practices? We've talked about surveys and samples. Certainly you can start to institute universal feedback. It's not that unusual to have little feedback cards at checkout and stuff like that. At this point, use your complaints. They're just another source of getting information from folks. And we're doing weekly waiting room surveys as well. We just sit and talk with people a little bit longer and have those conversations. And then, next slide. So again, how do you routinely ask about this experience of care and then really design what things you plan and do with your teams around that? So more regular focus groups we're going to talk about, patient representatives on the improvement team. Those of us who do have FQHC patient boards, that's always been, and it's been the first thing we've been able to go to. It's not enough, I would say. I think you really need, our quality improvement meeting once a month does have patient representatives there. And just keep asking the follow-up questions, the sort of whys that follow from the feedback that you get. Next.
Nick, do you have a fixed patient advisory group?
Why, here it is. On March 18th, our Patient Advisory Council, which is separate from our board, our 51% consumer board, meets every 2 months. Really just starts with sitting together, sharing their experience and any new information from their recent experiences in the clinic. We bring major initiatives like starting a walk-in clinic at Cascadia Behavioral Health or transitioning to a fully capitated primary care model to them for their feedback and showing them some of that's happening. Everybody gets to set future agenda items. I know we've got where is the self-care plan best going to live for those of you who are using the portal in my chart, or those of you who aren't, or if you want it on a piece of paper, do you want it printed every time? We'll ask them. That's going to be our focus group for that.
So that's separate from the consumer advisory panel for your CCO?
That's separate from our governing board. There's some overlap.
This is
a patient advisory council.
Richmond Clinic.
This is the one at my clinic.
Okay.
Right? And we're 10,000 patients or so, and so we have the mass to do that. I'm not saying it would always work that way for everyone, but getting a half dozen patients who care about your clinic, want to see it better. Sometimes they're the complainers, sometimes they're people with the chronic illnesses, sometimes they're people who just are full of good suggestions, maybe have worked in healthcare before. Whatever source you can get together to have a group that meets on a regular basis. And the difference is you're not just responding to your latest patient satisfaction survey, which is important and tells about the experience of every visit, but you're now able to engage in an ongoing way that can integrate with your planning and your quality improvement plan, if you will, strategic plan, if you will, and get more specific input in decisions you need to make for the future, not reactive ones to the past, ones you need to take for the future, like where will your care management plans live and how do patients want to use that.
You have board presence there?
There's a couple of people who overlap the two. Two members of our board are on the okay? All right, and this, don't read this, but this is a weekly email that goes out that tells us our most recent comments from just a week or two before. So we're just very active, what percentile we're in, what percentile we were in the last quarter or a year ago, what some of the themes of the comments were, and then all the comments. And we've been sharing that for years now on our scorecard as well. We very quickly stopped blinding to provider. We do list the providers. Just we all get used to it. I mean, we all often hear the same kind of themes. No one needs to take it personally, but obviously we're all having a little trouble running on time, for example. Next. So that's going on to us. So again, sharing that stuff. It's not just one quality manager putting it on a shelf, but really just getting used to seeing it all the time. We can pass this as just a patient-friendly way of talking about pain medication policies, where again, the distance between our goals and patient satisfaction was sort of often at the hardest intersection there. But go ahead, next. Okay, so motivational interviewing and the like. So this is like the softball, we get PDA, it comes from the motivational interviewing. The idea that it allows the directiveness that many of us are used to in the way we provide information. So semi-directive, but very client-centered counseling style for eliciting behavior change by helping patients to explore and work and live with their ambivalence for a while. I remember coming back from Cottage Grove to education training and saying, I can't really teach you about continuity care and behavior change in 3 years of residency, because sometimes it takes 5 years. And this is a set of tools to get into that ambivalence and see whether the change can enhance and move forward or not. There's trainings available, a couple of day trainings. I've been to one kind of a long time. I think you can self-train much of this stuff, and Espert's going to show us how to do that in just a second. But continually expressing your understanding of what the patient. Dr. Amanda Risser has a great speech she gives residents about, again, back to the pain thing. She just listens hard enough, and just those simple repetitions in an empathetic way of what they're being told de-escalates that negotiation without changing any behavior around the prescribing. So frequent expression of empathy, figuring out where the patient's situation that they see them in is different from where they want it to be. Where is this discrepancy between what's actually going on and where you'd like it to be? Rolling with the resistance. You can't argue, I love particularly this sort of fear-based approach, if you don't quit smoking, you're gonna die. Well, one, I don't know, maybe they're not, right? Maybe they're gonna be grandma who lived to 100 years old smoking. I mean, that's what they'll tell you back. And I don't think very little behavior change really comes out of a fear basis, except maybe in that moment of panic or at the end. I have some quotes here about even the most activated group of patients who are all about their self-management on top of it. A third of them say under stress it's all going to fall apart, right? That they won't be able to function in panic or stress. So the idea is not to raise the temperature on your patient, but rather to not let those buts, but I can'ts, stop you, and that's the rolling with resistance thing. And then continue to support self-advocacy. Next. Another tool to really look at the interaction and move yourself forward with that is this patient-centered observation form for Larry Mosh out of Washington. There's also, you'll see at the end of the website, straight from Doug, about it. And he's doing a lot of trainings. You were just telling me you've been doing a training down in Medford about it. We'll be back in Portland in April. So these things are around. I would say the trainings are useful because there's so much sort of flavor and a lot of background. I didn't steal all the slides for this, but the really important part is developing the internal observer. The set of attributes I'm about to show you aren't that hard. You probably run into them in bits and pieces somewhere else. but this idea that in your team, like your MA, or you and your partner, just a few times of watching yourselves, and maybe picking things that you're doing and could be doing a little bit more of, will lead to more patient-centered open communication that will save you time and get you more quickly to a shared agenda. Next. So it just breaks down into this set of domains. It's a piece of paper. Now that I'm going to drive this, I do think I've got a second to show it. So you're going to hear that. And the escape button and the observation form looks like this. So it's got this established rapport, maintain relationships, collaborative agenda setting up front, efficiency and transparent thinking, how you use the EMR, what you do with the physical exam, sharing information and behavior change discussions with some very specific ways of describing pros and cons of various options, for example. So it's pretty darn specific. This side is you're not doing it. This side is you're doing it. Here you're doing it a lot. It's not that complex. Of course, none of our visits are that linear. I mean, they ideally sometimes are kind of agenda setting and collecting and sharing information and physical exam and coming up with a joint plan and then doing a read back technique, one of the hallmarks of literacy work, to the patient understand, tell me again what you're going to do. But as you observe, it's usually a little bouncier than that. If you could just drive it back to the PowerPoint. So it's really not hard, and having it observed a half dozen times now, I really have learned a lot. And it doesn't something, you can do a couple of patients a half day with your MA. It doesn't even end up breaking up that much. Like one no-show is going to be time for your MA to observe you to do this, or for me to observe them check in a patient. It's really only a few minutes. And it really enforces a certain kind of mindfulness about the interactions with your patients that in itself is rewarding. One of those, how am I going to get paid for this? Well, really, it's a very small amount of time. And your own satisfaction or your own ability to get through a visit, I think, like I said, the best study that Larry Marsh had about a 90-second decrease in the visit time will reward that well. So this comes right off the Esbert, Oregon site. And again, just to contrast, what really is still what I observe tons in my learners and the students, and I hear about tons from my patients in their specialty visit, is telling patients why they should make this change, telling them that they should, telling them it's really, really important, maybe trying to scare them into it, and then when they hear the buts or you hear the boundaries, to try and force your way past those. Next. As opposed to a more guiding communication that still has goals that we're working with for our patients, but acknowledges their autonomy on that curve we're describing, asks them about their goals and values, assesses readiness to change, is comfortable with and works with ambivalence, lets the patient choose from at least some menu of what the targets, and remains non-judgmental and respectful. Next. So these brief interventions can be short. We're really not talking about a long conversation or tons of background. They're applied in relation to the risk. So everyone was talking about how you get your lists and who's on your high risk group and who's not. The people who are at the highest risk are the ones you're going to invest the most in. Next. And simply going there, giving the patient some of the information and feedback about the concern, checking out where their motivation is and maybe identifying where the positives are in that, rather than just working on all barrier overcoming, right? The general thing is if you're at a scale of readiness to change from 0 to 10 and you feel like about a 3, you ask them, well, why isn't that a 0? Why isn't that a 2? Try to identify some of those positive aspects and then negotiate a joint plan. Next. So if you're using some sort of screening format, if they've been screened with an intake tool for the group visit, whatever else, or if you're just, hey, thanks for telling me about your drinking, for example. Go ahead. Next. Saying where we interpret their risk thing, where that means where our concerns lie. Next. And then, how ready, would you be interested, are you interested in changing? Remember that I said about the discrepancy piece? Is there a discrepancy piece from where you are and where you want to be? How ready are you to change that? Why isn't that less? And then sort of picking up from there where your shared plan will be. Last couple of slides. Next. So, for a plan, being clear about what your advice and goals are, agreement changes willing to make, and this can also include that 5A model that everyone was talking about in terms of what other resources will you send somebody next. So that's the Esper tool. Again, you're all going to get to know this pretty well. There's a little pocket card they give you. You go, oh, here's your change thing, and here's the level of drinks that we mostly consider safe, and here's what risky means and harmful means and dependent means. Yeah.
When I do this, I find that I push my computer to the side and I make direct eye contact and talk with the patient, and then I have nothing in the chart.
Right.
Any suggestions for, how to document this and what we're supposed to do?
Sure. There are Esper dot phrases that are right on the Esper Oregon site. Next slide. Actually, that's on there. It's right on the Esper Oregon side that I would absolutely make, .hb Esper if you need to make it custom or make sure it's done. So certainly if you're using that kind of tool part. Again, if you're using it off a paper-based system, let the paper live and be that documentation. Because I agree with you completely, except I would ask you to start to shed your concern and get your EHR to maybe have one place where that lives so that you can concentrate on the conversation and not the documentation of it. Because it's really that going there, discussing it, and either wherever your little, problem, at-risk drinking, no change, planning change, trying to limit to 7 per week, whatever your place where that lives, just leave it to be to that. I'm finding Note Writer tremendously helpful in being able to work with the patient and not have the computer as intrusive, but that's me, I'm not a typist, it's click stuff, it's all just pluses and minuses. The Larry Mach forum has a set on using the EHR and acknowledges that we will want to get some stuff in there enough so that the end of our day is easy. One of the main things, of course, is turning the screen to the patient and letting yourself have a space where that happens or not, and setting up the interruption. So you're allowed to interrupt, but you have to apologize and say why, and why it's in the patient's interest to interrupt.
And on that website, they actually have videos of medical students kind of doing a not so fabulous patient interaction and then a better patient interaction. And one of the things he focuses on is it's never perfect. So just making it better is good.
And I'm going to make a plug for the Payment Reform Act aspects of this, whether it's per member per month additions to carry out this additional work, or if ultimately we can get away from justifying every 214 by making sure the 4 or 5 elements are there and concentrating on the interaction and having that live in a single place so that it's not repeated every time. I just sort of keep that in mind as you work out your care contracts with your CCOs and that sort of stuff. Does that help a little bit? Okay, well, I don't want to keep people from lunch, and I think we're right about on the minute, but you got some hands up, so, but people have permission if they're hungry.
I think I'm feeling like it's easier for me to have the shared collaborative experience than the agendas one that the patient's bringing in.
Uh-huh.
An acute or a problem, I remember the one time a patient said my blood pressure's 138/96, I want to be 120/80, and I just about fell off my chair.
Yeah.
It seems when it comes to chronic disease and preventive care, it's my agenda or the insurance company's agenda, and I'm having a hard time making that be the patient's agenda.
Right. So the standard answer to that is pick up what their health goals are for the coming years and decades, because this is the time frame you're talking about. Develop a link with the blood pressure part. Give up your immediate action goals. Your action goal probably is less than 140/90 as soon as possible.
Right. I mean, the A1Cs are the classic. I'm like,
And
my
A1Cs are the
is
classic.
8.2, I feel great, I don't want to go on insulin.
you will get just as far with your A1Cs, and again, this has been shown repeatedly, if you almost give up on that as the goal and get back to what the patient cares about. Often those will align, sometimes they won't,
Right,
but they will later.
right.
You're allowed to say, well, A1C is what we measure because we know it's the best predictor for heart and kidney outcomes in the long run.
Right.
So I'm not going to drop that agenda piece. But right now, let's talk about,
It almost makes me think about instead of having the patient scorecard that's got A1C, blood pressure, weight, it should be blank.
right.
And
Well-
the patient should fill in the 5 things that we're gonna score on.
Uh-huh.
And just
That's great.
forget the other half.
And I will say that in our quality meeting, that's been particularly helpful because, we've got a bunch of things from meaningful use and from the CCO lab. We've got a bunch of things from UDS stuff for the FQHC that we're all being asked to measure. But what we choose to put our attention points on is still up to us and our patients. So right from the top level about what do you push hardest on your quality improvement plan, right back to your interaction in the room, I want to encourage you to let go of some of the measured goal setting and find the intermediate behavioral steps for the patient that work for them, right? Now, I want to be able to watch my grandkids. What's the hardest thing about watching your grandkids? I can't chase them around the playground, I get out of breath. How do we get you in better shape to do that? Your A1C will get better from that as much as it
Right.
will from another discussion about medication and medication compliance. Not that that can't be part of it as well,
No, but
if that's their
helpful.
piece. So in the hand, yeah.
So, we've got, I like patient portals, but I have patients, I find myself negotiating a diagnosis with patients. I want that off my problem list.
Oh,
I'm not
yes.
depressed.
Yeah.
Oh, yeah.
Or, you got alcoholism on here, and I don't agree
Yeah.
that that's alcoholism.
I don't have a personality.
And,
disorder.
So I haven't found the ICD-9 code for at-risk drinking or try, I found, alcohol abuse.
Yeah.
And so I'm trying to find language that's acceptable, because they do see the problem list
Yeah.
on the MyChart portal, and so I find myself negotiating diagnoses.
There's also a display as function though
It-
on Epic.
You can do,
For
yeah.
each diagnosis, it's what's the code and then what does it display as?
You can change what
You can
it's
change that.
written as, but in the background
But
it
that's
has.
what-
There's
Oh,
a new,
okay.
there's a new little
Cool.
checkbox that
You
says
got
My
it.
Chart.
Oh,
There's a
cool.
new little tiny checkbox.
I like that.
And if you
I
check
gotta
that
have, I gotta have
box,
somebody teach me that.
it doesn't
So-
display on My
Yeah.
Chart.
Right. So yeah, there is how you work with that. Again, I feel like this is relatively strategic and you want your
Yeah.
patients involved in that early. One of my biggest aha moments for that was just copying the page for borderline personality out of DSM-4 and handing it to the patient one day and saying, there's just this thing here and I'm just wondering, do you recognize any of this stuff? Yeah. Like, me and my peers were so judgmental about that label, but when you got into the pieces of it,
Yeah.
the patient got it fine. So it was only one step there to say, well, this is what we call this, and it's just a way. It's not. I'm not telling what Joan is. Joan is Joan, but this is one label that's going to help me think about you.
But they don't
so
like
here
seeing
it's
it on
gonna
their
be.
problem list.
I know, but I don't know. I am finding that
Yeah.
the problem list has not been as much of a problem for me in that regard as it's when I'm not entering when that change is made early in the visit, right in the agenda setting, today's visit diagnosis, and this one, hey, we're going to be talking about this over the years, so it's going on your problem list. That's certainly much easier than a cleanup conversation later.
Thanks.
Do you have a way of tracking the degree to which a patient wants to be seen? One of
No.
the things that I've struggled with is not seeing patients who don't need to be seen.
Yeah.
And moving away from we see this person every 3 months, or every 4 months, or every 6 months, or whatever, and to empowering them to call us if their blood pressure goes up,
Yeah.
and have them manage it themselves. And so it's somewhat difficult for me to figure out how to deal with individuals who are obviously different, and when some need to be seen very frequently and some don't.
Right. One, we're still enough of a mixed system that I routinely find times when I'm kind of okay with visits going back up again, even if it's not the most useful visit I'll have that day, if there's not that much to max pack into it. So if that's where the patient's at, there's something called, I didn't include it in the slides, but Judith Hibbert always just uses the patient activation measure, and there's definitely patients who score low on that. And there, if we can do some of the hand-holding, MA visits would be a really easy one when it's about blood pressure or something that's, point of care measured that you could maybe tag on to. I certainly am looking forward. The estimates I got in this here is that most of your care plan follow-up, the little times you send yourself a reminder, hey, I would love to call this person in 2 weeks and see if they met their exercise goals or not. Almost none of us do that. It just gets pushed to the side. But it's probably only about 1 to 3 hours a week to follow up on these because so many of them are relatively static or long-term care plans. So those extra touches. So again, potentially transitioning, again, with the team-led interaction that the PCOF encourages, we are trying to displace some of the relationship onto other members of our team, so medical assistant visits. And I would probably say if that's really the model and the patient scores low on patient activation measures, that's one that you're gonna see, and that's okay. Just make it easy enough to be quick enough, preload enough, plan that visit ahead enough, that it won't take up much of your time. Okay, thanks everybody.
Thanks.